Sethi.
Thank you very much, and a very good afternoon to all. Can I have my presentation, please? Okay. Traumatic cataract and managing the loss support. We all know that trauma is, as the name it may sound, is that it always gives you this feeling that whenever the patient says trauma, that means you have to actually be ready for just anything. And you need to strategize right from the time when you get the history of trauma, re-strategize and still be ready for a surprise. So depending on the injury type of injury, is it a blunt injury or a penetrating one, it could be associated with cornea or scleral tear. There could be an anterior lens capsule breach with loose lens matter in the AC, PC dehiscence, zonular dialysis, or hyphema. Now the first case is a case of a 55-year-old male. Came from Afghanistan with a history of blunt trauma in a bomb attack 6 months back, and came to us with a mature cataract in the right eye. Zonular dialysis was noted inferiorly, and the UBM showed about 2 to 3 clock hours of zonular loss. The ultrasound B scan also was done, and it showed an attached retina, no vitreous hemorrhage. Now, what was our plan? Should we do a phacoemulsification with the CTR? Should we keep the option of SICS or extra cap ready? Do we need a VR backup or not? So here we go. This is the patient who had come to me, and we could see that the bag was very loose. It definitely didn't sound that it had just only 2 to 3 zonular dialysis, hours of zonular dialysis. There was a lot of difficulty in completing this rhexis. The problem here was that it was noted that there was a lot of zonular dialysis, and for that there was a lot of prolapsing of the vitreous that was not enabling us to complete the rhexis. So anterior vitrectomy, or rather the prolapsing vitreous, was taken out by an anti-vitrector. And loose cortical matter was very, very fluffy. And what we did was we just completed the capsulotomy, and here we stopped to construct our 2 scleral pockets, which should have been like, we need to make them completely 180 degrees apart. The scleral flaps were made, and after which, this is very important here, is that they should be 180 degree apart and in the same plane, and a lensectomy was done. This lens was taken out because definitely it was a very loose bag was there, and the bag was not even getting, it was very difficult to manage. The anterior vitrectomy was performed, and these 2 sclerotomies were made with the MBR blade, so that these could be helped, we could get this help in putting up our, tucking in of our intraocular lens. The AC maintainer here was very important and handy, because it helped maintain the positive pressure in the eye, and the sclerotomy was completed, and these lateral 2 Shariat's pockets were made with a bent 26 gauge needle, and we completed our core vitrectomy. This is important to complete core vitrectomy at this stage, because you do not want any vitreous tugging onto the intraocular lens, and a complete vitrectomy, core vitrectomy was done. Now, from the main incision, here we loaded up our lens. It was a 3-piece lens, and with the holding forceps, once you put it in the anterior chamber, just very slowly get the haptic to reach your forceps, IOL holding forceps, and this slowly, very gently, because these lenses the haptics don't have that much of a memory, so very gently hold only at the tip, and the haptic was tucked into the pocket. So, this is important that we need to just tuck this very gently, and this could be repositioned later once you have done the other haptic also, and the scleral flaps are sutured in place. So the take-home message in this case was that we were fortunate that we were prepared, and we had strategized, and we had prepared a good VR backup. So this is case number 2. Now the adult trauma and trauma in a pediatric case is a little different here also, because this is a 6-year-old child with a history of trauma with an elbow, came with a traumatic cataract in the left eye. There was no phacodonosis noted, and the indirect showed that disc in the retina was healthy. But it was difficult to really assess the maximum part of the. Now here the loose capsule, loose zone, the lens matter was aspirated, and a very gentle IA was done. Now here there was a little area where the dehiscence was noted, and also there was a rupture of the posterior capsule. A vitrectomy was performed, and the lens was put over the surface because it wasn't a big, gap in the posterior capsule. So we could implant the lens, and the aspiration of the viscoelastic was done. And in pediatric cataracts, it's very mandatory that we need to suture the wound so that there is no leak because of their rigidity. Thank you so much.
Thank you, doctor. One thing I wanted to know from you. Number one, after doing anterior vitrectomy, you didn't check it by putting triamcinolone injection.
Yes, yeah, that is one thing which should have been done.
Number one. Number two, you did not mention about preoperative visual acuity status and status of the intraocular pressure, because they are of paramount importance while planning any surgery for traumatic cataract.
No, I had noted, but I haven't mentioned in the thing.
Do take care. Thank you.
Thank you. Should I give Dr. Sahiba's presentation also, if it's okay?
Yeah. Second also she wants to give. You want to go with the other one also?
Yes.
Phaco surgery in anophthalmic eyes?
Yes, sir.
Okay, please go ahead.
So surgery in an anophthalmic eye, as we all know, anophthalmos is the abnormal smallness of one or both of the eyes in all dimensions. And there is absence of, and the incidence is about 0.004%. Inheritance is sporadic, autosomal recessive. Now, basically, how small is an anophthalmic eye? So there are various views, and some have said that it is less than 18 millimeters, and or less than 17 millimeters, less than 20, and the Journal of Cataract Refractive Surgery 2004 said anything less than 20.5 is a small eye. Now, there has been no consensus as such as to how small should the eye be, and what is its features. Basically, here, why is it a difficult situation? Because when we are operating on such eyes, we encounter narrow palpebral fissure. These eyes are a deeply set globe, and there's a short axial length. The high axial hypermetropia is there, small to normal corneal diameter, and what we really encounter during surgery, and which is the problem, is the shallow anterior chamber and the high lens to eye volume ratio. Abnormally thickened sclera and choroid, which is more than 1.7 millimeter posteriorly. So basically the normal eye, and this is what it is if there is an anophthalmic eye, because of the difference in the ratio as well. Why is it challenging? The 10% risk of complications intra-operative and post-operative because of the uveal effusion, hemorrhagic choroidal detachments, and CME PCRs, which are more common in these cases. They could be also because of the zonal dehiscence, and the operative difficulties which we encounter because of the anatomy of this eye. There could be a need for a sclerotomy to reduce the pressures, and associated comorbidities like the glaucoma, Fuchs endothelial dystrophy, or limitation in biometry is one big important part, because we really don't know how are we going to be accurate in our IOL power calculation. So we need to be more specific in the formulae we use, and the need for this residual refraction surprises which we get. And the important part in these patients before we do the surgery is a proper patient counseling about all these problems, get a proper detailed consent from the patients and the attendants, the adequate IOP control if the patient is having high pressures, and biometry, which includes proper ACD, lens thickness, scleral thickness, all has to be kept, and you have to have the specific formula which I'll be dealing later. The IOL selection is very important, and endothelial cell count and pachymetry is important also, because it's a narrow, it's a shallow anterior chamber, so you need to be very careful to use the proper viscoelastic, and the ultrasound biomicroscopy, evaluation of associated comorbidities are also important. And what are the issues faced during surgery? The various dilemmas are, should we do it under a general anesthesia or should we give a block? General is definitely preferred. The eye is a deep set eye, so during surgery you have to be very careful about the pooling of the fluid. All that has to be thought of before only. Normal surgical space in the anterior, narrow surgical space in the anterior chamber, protection of the endothelium with viscoelastic, suboptimal dilatation, increased positive pressure in these eyes, and incidence of iris prolapse because of this raised IOP, and suprachoroidal hemorrhage to avoid in cases of these nanophthalmic eyes. What to deal with after the surgery? After the surgery would be a residual refractive error, inflammation control, glaucoma or uveal effusion, which could happen in these patients. Now, these small eyes have big dilemmas. And what are these? Should we do a preoperative PI or not? So for management of angle closure glaucoma, lens extraction is definite. A laser iridotomy or iridoplasty is temporary, and we can do the iridotomy, which could temporarily give us a control. And glaucoma filtration surgery in cases the high chance of malignant glaucoma or patients' pressures are not getting into control. Should we do an extra cap or should we do a phaco? Now, the current recommendation is phacoemulsification because it's a closed chamber and you are more in control of the environment. There's high chance of complications in these patients. Extra capsular cataract extraction is suitable in intumescent lenses, or if you feel that the eye is very crowded and you cannot, you're not that proficient that you can handle these cases with just phaco without giving any damage to the endothelium. Prophylactic sclerotomy or not? Some patients do require this procedure also, only if there is pre-existing uveal effusion or has been a bad, patients are going to be having bad follow-up and you don't know whether the pressures will be going high or not. Now, which IOL formula should be used? That is another big dilemma here. The third generation formulas Hoffer Q, fourth generation formulas Holiday 2, Haggis, and the Barrett's formula. These formulae are now proven that they give you better close IOL power to the required IOL power calculation. A recent study by Cariff has confirmed that superiority of these formulae over the SRKT formula. Now, how to select the IOL? Choose the highest power IOL available for these patients. The Acrisoft SN6080, for example, is a single piece hydrophobic acrylic IOL that comes in powers up to 40 diopters. So the residual refractive error can be corrected, and you could even use some piggyback lenses, but here we have to always remember that is not a good idea because you can do the residual by contacts or by spectacles. That will be a preferred choice. Now, how many IOLs can you implant in these patients because of this high prescription? Aim for always a single IOL. Piggyback lens, one in the bag and one in the sulcus. Both in the bag, high intralenticular opacification is the problem that you have. And so I think better would be that we get the maximum correction in the first lens only. And pars plana vitrectomy or anterior vitrectomy or neither. In the most extreme cases, a vitreous tap can create increased chamber depth. So here, because of the crowding of the anterior chamber, we need to create more space. The greatest challenge for a limited vitrectomy in these cases is the altered anatomy of the nanophthalmic eye. So it's a little difficult situation. So this is a short video of how the sclerotomy can be done in these patients, especially those who you feel that they have chances of choroidal effusion, or they have too much of a very small eye, crowding of the anterior chamber. The scleral flaps are raised. And a second level deeper incisions are made, preferably a triangular flap kind of a thing. And then the wound is closed. And you can continue and proceed with a your normal phacoemulsification.